Good evening and welcome to Creating a Culture of Impact, Stories of Community Quality Improvement. Tonight's program is part of Empower 2021, Frontier Nursing University's virtual event in celebrating National Midwifery Week, and is sponsored by the FNU Institute for Healthcare Improvement Open School Chapter. I am Dr. Cathy Collins-Fulea. I'm a certified nurse midwife who practiced for 38 years in Detroit, Michigan, before becoming a full-time assistant professor with Frontier Nursing University 2.5 years ago. I've been involved with quality improvement since, now I'm showing my age, the early 90s, 1990s that is, implementing a number of clinic-based initiatives, improvement initiatives, as well as sitting on the National Quality Forum's Perinatal Measures Steering Committee and the Joint Commission's expert panel on perinatal measures. I also led the development of the ACNM benchmarking program and the ACNM's handbook on quality management. So really, I guess you could say I'm a quality improvement junkie. As president of the American College of Nurse-Midwives, I was very pleased when asked to moderate this panel because also it's National Midwifery Week. Midwives, really are uniquely positioned to see gaps in care and implement evidence-based quality improvement programs to close those gaps. The format for tonight's program is Pechakucha style. Pechakucha means chit-chat in Japanese. Our CNM faculty and alumni panelists will connect us through visual storytelling of midwifery quality improvement that they conducted in their own communities. Each presentation will last approximately 5 minutes as presenters share a series of images while telling their story. I'd appreciate it if you could please, everyone keep their camera off and their microphones muted, except for the person who is presenting so that we can all focus our attention on the presenter. We'll open the floor at the end for a brief discussion if there's any questions, and then you can all turn your cameras back on then. That would be great. Now, I would like to introduce our first presenter. Dr. Shanice Vines is an alumnus of Old Dominion University, where she earned her bachelor's and master's of science in nursing. She was trained in midwifery at Shenandoah University and later earned her doctorate of nursing practice degree from Frontier. She serves as assistant professor and course coordinator at FNU and is a research clinician for the Thrive study at the University of California, San Diego. She is also the founder of the Coco Health, a telehealth platform providing women's health services to women of color by clinicians of color, and is a sought-out speaker. Dr. Vines has loves serving within a community of organizations which she belongs to, including the California Nurse-Midwives Association's Professional Practice Committee, the Reproductive Justice and Anti-Racism Committee, ACNM's Program Committee, and the Black Nurses Association. So welcome, Dr. Vines.
Hi, thank you for having me. Thank you for being here tonight, everyone. So I'll start with my story starts as a public health nurse. That's where my roots were as an RM. And I think that that's been the foundation of my midwifery career. The meaning of midwife is now as a midwife, I actually still worked in the public health setting. In addition to our clinic, I would also be a part of various community health projects. So this is a picture of me talking to people about vitamins and prenatal vitamins and preconception care, talking about foods that are healthy, talking about places to go to get these healthy food choices. Next slide. One of the things that I noticed was access to care. Many of us, I think, enter into this profession to serve communities that have similar stories to us, or that where we notice gaps in care. And so being a person of color and an African-American woman of color, that's been my target audience. And so I recall when I was a midwifery student that in order to birth at this particular birth center, that people had to get an improved education class. And that was a barrier to some because of finances. And so what I began to do was to offer free or reduced price childbirth education classes to these people in this community. So that way that was no longer a barrier for them to have access to this birth center level of care. Next slide. After working at the public health department and also hosting those classes, I moved to a hospital-based practice and a private practice model. And so I really got to work one-on-one with patients and clients and really educating them about preconception, about the antepartum, about just their whole well person experience. Next slide. And so this is one of my favorite births, one of my favorite patients. I remember this person very dearly, just being able to build relationships with people who traditionally were not trusting of medical providers, who did not know what midwives were, being able to bridge that gap and to be able to educate patients where they were and to help them achieve their best health. And I think that really is what equity is where we're helping everyone to be at their optimal self and overcome those barriers. Next slide. So as I started to do my DMP program, I really began to have a change in mindset. And I think this change in mindset has guided me for the past couple of years, where I wanted to look at how we did things as a practice. And now I look at the way that we practice as midwives and the system that we create for our clients and people that we serve within the community. So this was one of our stakeholder meetings with my collaborating physicians and some other people from our team, talking about our gestational weight gain that we had amongst our patients and how we could really work from a QI and QA perspective to address those things. Next slide. Outside of the project, it really got me thinking after I got my DMP of how I could really impact change on the community level. And so what I started doing was hosting different forums where, again, we had a gap where providers were not talking to each other. So we as midwives didn't know what our FNP colleagues were doing for our patients. And then there was a shortage of mental health care providers in our community. So we provided forums where we had all different specialties just speaking to the community to answer their questions and to help bridge the gap and create care connections. Next slide. Or just promoting the screenings. Next slide. In addition to our community, just continued serving women of color, particularly African-American women. And so carrying that message nationwide. So I began to start speaking about just what midwives are, what we do, the importance of reproductive health care, women's health, and speaking to larger audiences and really becoming more relevant to the millennial generation. Next slide. This is my baby. This was Healthy Her Center for Women's Care. It was the first and only midwifery-led practice in our community that bridged the gap where services, mental health care services, primary care services, in addition to other services as well. And so we really embodied that. And we really tried just to have people be partners in the care, which I believe is a strong tenet of midwifery care. And so this was our lobby. Next slide. And so lastly, due to COVID, we've also had to revamp with how we can see people and how we can interact with people. And also just with everything we're seeing with health equity, and also with my research with medical mistrust amongst African-American women. I've actually transitioned our practice a little bit based upon that research where we want to improve trust and we want to improve access. So we've started a telehealth platform where we primarily service women of color by clinicians of color. And we're offering midwifery services, we're offering family planning services, we're looking to offer virtual doula services, and we also have a couple of licensed professional counselors on our staff as well too. So this is just our way of caring for our community and answering the call and hopefully helping to improve the midwifery profession. Thank you.
Wonderful, wonderful story of how you impacted change in your community. It's a lot of work, but look at the great outcomes that you're having. So thank you for what you do. Our next presenter is Dr. Anna Verzone. She is an FNP and a CNM working with rural populations since 2004. She's taught at the Frontier Nursing University since 2018 in both the Doctor of Nursing Practice Program and the Family Nurse Practitioner Program. And previously, before that, taught at the University of Alaska's FNP program. Dr. Verzone is passionate about global and rural health and training excellent clinicians who take into account the wholeness of a patient. She's currently living in Alaska. She's worked in various settings, including with the Rural Anchorage Service Unit and Alaska Native Medical Center, providing primary, urgent, and emergency care in rural Alaska. Also as a hospitalist midwife with the Providence Medical Center and as a provider at the Integrative Medicine Clinic in Anchorage. She enjoys international volunteer work and has served in Uganda, Indonesia, the Dominican Republic, Nepal, and more. So welcome, Dr. Verzone.
Great, thank you. I'll have to shorten that bio, right? It's a bit long. So thanks, everyone. So go ahead and move to the next slide, please. So this is a photo of me and my family, and my kiddo's a bit older now, but I just love this photo because this is us after a bike ride. And we crossed a frozen lake on fat tire bikes and rode all the way out to this glacier. And it's just an example of how different everyday things like family outings are here in Alaska. And we have a lot of wild nature around us, and that lends itself to some amazing experiences and also some unique challenges. Next slide. So one is weather, obviously. In my work with the Rural Anchorage Service Unit, which provides care to a lot of rural areas of Alaska, like there are some areas where they get maybe like one barge a year for major supplies, for example. And I used to fly to the bush with my husband, who's a physician's assistant, and we would have the craziest rides on bush planes, ice building up on the plane, very poor visibility, wild turbulence, cowboy pilots with no kids, no family, nothing to lose for them, you name it, right? And I actually stopped going out on the smaller planes after I had my kid because my risk threshold really changed. So but even then you can get stuck out somewhere for weeks. And I think the longest time we were stuck was over 2 weeks out in Sandpoint due to inclement weather. So you have to be flexible that way. And we also have transportation limitations, like the area is accessible only by barge or plane. And where if the weather's bad, they may not get food. And if they want something bigger, like a four-wheeler or a truck, they may have to wait for that once a year barge that comes and brings out that stuff. Next slide. This is a rural village in Alaska. It's not hard to imagine why fresh food is hard to access or even grow, right? For exercise, many people are put off by the weather or by fear of bears, for example. And many clinics in these areas only have limited medicine available. The local pharmacy is also very limited in what they carry. And if we want to order a medication that's not immediately available, which is often, we have to have it flown in, which takes time and refills can be delayed. So it makes continuity of care and compliance very challenging. And communications are also a challenge. I was mentioning earlier before we got on, I'm in the biggest city near downtown, and I still have to tether off my phone for presentations because it's unreliable, even here. And out in the villages, we have access to an ER doc at the native hospital often or to other specialists, but we can't always reach them if the communication's down. And it makes it challenging to have reliable records. Often the system's down and we can't even chart, for example. So high-speed internet access is actually a priority to improve access to telehealth services in these areas. Next slide. The Rural Maternal Child Health Program at the Alaska Native Medical Center is headed by a nurse midwife, Margaret Baldwin, who does the best she can with the resources she has to follow pregnant women in the rural areas and postpartum as well, but it has many challenges. But despite these challenges, Alaska has a very innovative, successful program in place with perinatal regionalization. I did a presentation on that for Rural Health Week, so you can check that out if you want more details about that. But we have medical hubs where there's higher levels of care, like C-sections can occur in those hubs without coming to Anchorage. And there's also community health aid providers in rural areas that can do basic prenatal assessments. And the people are flown in to get midwifery or specialist care at the Alaska Native Medical Center as needed. And if a patient doesn't live in a hub, they're flown to Anchorage at 36 weeks with one family member or a partner or a friend, which presents its own unique social challenges. So this is a photo of a woman who's just delivered and will be returning to her village after her stay. Next slide. This is another photo from an area called King Cove. With a notoriously scary plane ride due to topography of the area and how it funnels the wind. And I just love how it has a sign for kids at play and a bear warning sign on the same pole. And out of all my years in Alaska and hundreds of days in the wilderness, this village was the one and only time I ever carried a gun when walking around. Everyone told us not to go anywhere without one. So I figured I should listen to that wisdom because they're particularly aggressive there. So that sign is real. So it's kind of hard to recommend, hey, go for a walk during your lunch hour when like this is the environment in some places. And while many patients in most areas get a bit excited when I had to send them to Anchorage for care so they could get to the big city for a bit, here it was not uncommon that a patient would cry when they found out that they had to get on the plane. There used to be a hovercraft, but it broke. You can imagine trying to find a hovercraft repairman in Alaska. It's not going to happen. So it's just sitting there. And once mothers return to their village with their baby, it's hard to keep track of them since there are not many rural providers comfortable with midwifery type care, and many people can be lost to follow-up. So I was one of the few nurse midwives also trained as an FNP, so I would be able to go out not just to see primary care and urgent emergent patients, but also meet with all the pregnant women in the area and postpartum women as well. And the clinics really appreciated that because they didn't have the resources to fly out midwives on a regular basis or for a midwife to be there for longer periods of time. But they do fly out OB-GYNs every few months to do more specialized ultrasounds and assess higher risk pregnancies. Next slide. So I've had the fortune to bring midwifery care to areas outside of the US as well. I volunteered in the Dominican Republic, Bali, Mexico, Nepal, Uganda. And this photo is where I was in Kisoro, which is a refugee camp in Uganda on the border of the DRC, the Congo, and Rwanda. And at this time, there were many people fleeing the Congo due to an insurgency. And here we were seeing pregnant women in the refugee camp and also training local midwives. That's Patricia in the background. I still keep in touch with her to this day, and they were amazing. So there I was able to do weekly in-service classes and did a lot of mentoring and learning from them as well. Next slide. I also completed my DNP project in Nepal. Nepal holds a special place for my family, and my husband and I met there when we were professional climbing guides in the 1990s. And our daughter Maya, her name means love in Nepali. And my project there was originally starting with the focus on improving communication during emergent obstetric transportation from rural clinics to tertiary care facilities in Kathmandu. Because the ER was saying people are just showing up when we have like no preparation. No one tells us they're coming or anything. And everybody's got cell phones and things like that there. So it is possible to call in, but it wasn't part of the culture of care. And so I did end up broadening it to all emergency transport since the ER said they really needed that more broad spectrum help. So they described that people would show up needing, for example, like massive blood transfusions and how it would be helpful to prepare for their arrival in advance with assembling the team members or being able to type and cross blood in advance, right? So this is a photo of, similar to Alaska, the transportation challenges that exist. So this is during the monsoon. You can see how bad the roads can get. This is like a regular road. And we had to get out of the car and help the Jeeps get unstuck many times just going out to a clinic. And often the longest part of our day was just getting there. And this gentleman here with the mask just hanging up his face, this is pre-COVID. He's a community health aide. Pre-COVID, he was wearing a mask in the Jeep because he had a cold and he didn't want us all to get sick, and none of us did. So I have an appreciation for masks, even pre-COVID. Next slide. I went out to 18 rural clinics and held in-service with locals about SBAR and the importance of handoff communication. And you can see the details of this project in the Frontier Digital Depot, but suffice it to say that SBAR is not appropriate for everyone and everywhere. And we had to do a lot of tweaking of the format of handoffs. And the trainings were really fun and also challenging with the language barriers that were in place, but overall it was quite successful. And here's a group of folks practicing and doing some role playing with SBAR. Next slide. And this is a clinic I went out to that was holding a women's health clinic. And these are all the local women in the village who showed up. And the rural health aides are often trained in the basics of midwifery care. And they were holding these clinics that are really popular where they educate women on various topics each time, such as contraception, complications of pregnancy, intimate partner violence identification, prevention and resources, and more. And there are also more women being trained in advanced midwifery care, but they have to leave their villages and train in Kathmandu for extended periods of time, which can be really challenging for their families at home. And there's sort of a brain drain where once they're trained, it can be hard to encourage them to go back to their rural village where there's very few resources and more challenges. But there's been a lot of success with these programs as well. And I chose this slide to end on because for me, it's a reminder that midwifery care isn't just a science, right? It's a movement. And it impacts everyone in the world because as we know, as midwives, right, a woman's health at the center of the family, and it impacts the well-being of her family and community. And yeah, even of the country, and ultimately how humanity interacts with one another. And so I feel really strongly about midwives advocating for quality improvement. We see so many gaps in care on a daily basis where we can make an impact. And I feel really fortunate to be able to do these projects in really amazing areas, and that a lot of what I learned at Frontier, my DNP program, has helped me to do that. So that's it for me. Thanks.
Wow, thank you, Dr. Verzone. You really take the mission of service to rural communities, FNU mission, seriously. And I what a difference the reality is of trying to bring care to those rural communities when, you know, we whine if we don't have the right size gloves or something. So it's just amazing. Thank you. So next we have Dr. Melba Black, or Melba Craft Blackshear. She is a graduate of FNU CNAP class number 4 and a proud native Detroiter who's concerned of the city's third world status for Black infant mortality and her desire to provide safe, caring maternity services initiated a compassion in her to become a nurse midwife. Her plan as a midwife at Hutzel Hospital was to stay until retirement, caring for women and infants of that community. However, as the only midwife of color, she was laid off after 4 years due to hospital cuts. Then, despite experiencing 4 urban area hospital clinic closures, she continued working with the community organizations that shared her desire to provide supportive infant and maternity care. When full-time midwifery jobs were not available to her, she began teaching maternity nursing to share the compassion for mothers and babies with the next generations of nurses and future midwives. Presently, Dr. Craft Blackshear is a full-time tenured associate professor at the University of Michigan Flint, teaching maternity nursing. She remains active in social justice issues, and her research focus is maternal child health and the diversification of the nursing and midwifery profession. She's published over 6 articles related to the Flint water crisis and its effect on maternal child health. Also, a book chapter, Transcultural Perspectives in Childbearing, was published in 2020. She has additional publications, including COVID-19 and the Communities of Color, which was published just this year. She also serves on the Michigan Mortality and Morbidity Review Committee. So welcome, Dr. Craft Blackshear.
Thank you, and I'm so happy to be here. In 1980s, I'm a native Detroiter, and in 1980, the Black infant mortality rate in Detroit, that's kind of turned the wrong way, but the Black infant mortality rate in Detroit was 21.8. In Michigan, it was 12.6, and in the US was 10.6. So that was very upsetting to me, and that was a reason why I wanted to work with the maternal child infant population. I started out at a community organization called Operation Get Down, the birth program. The birth stands for Babies' Inalienable Right to Health. Because of the infant mortality rate being so high, this was a grant-funded program where I worked teaching childbirth classes to pregnant teens. We would pick up pregnant teens from the east side of Detroit, bring them to the facility. They would get 2 really good meals. They would get childbirth classes. They would continue their high school education there, etc. Eventually, what we decided to do was to open the birth teen clinic, where we had nurse midwives from Hutzel Hospital come over and give care at the clinic. And I was the nurse, the RN that worked in the clinic with the midwives. This was the first time I had ever been introduced to midwives. And I was just so impressed by the care that they gave to the pregnant teens. And that's what made, and I found out about Frontier, and that was the perfect program for me. Being a mother of 4 children, a husband and a dog, it's like, this is the only way I could do this. So this was the sign that was in Kentucky when I made it my way to Frontier, and it was one of the best decisions I've ever made. Next slide, slide, please. Oh, okay. This is in 1994, I became a midwife at Hutzel Hospital, and it warmed my heart to work with women in the community, women that looked like me, doing the teaching, being very close to them, their families, etc. And this is a picture. Many of the urban hospitals had agreements with clinics with the Detroit Health Department system. And we just had a wonderful time working with the patients and teaching and learning and delivering the babies in the hospitals. Next slide, please. Additionally, and as was indicated, I'm teaching now, and this is something I truly miss. At the clinics, families would be there, they would bring children with them, and we would have the children help us find the heart rates with the monitors, and it would warm my heart to see the little siblings smile when they can find their own, the heartbeat of their new coming sibling. And this is what maternity care is. This is what midwifery is, being with women and helping them learn as much as they can and supporting them and listening, being with women. This was very important. And I do miss this, you know, working in as a faculty member. However, I keep telling myself, I sleep at night. And then I know that when retirement comes, there's still some things that I can do. Next slide, please. We took pictures of all the moms and their babies that we delivered, or if one of my partners delivered and I didn't get a chance to be there for the delivery, they really enjoyed. And I just love the idea of coming in and seeing them and their babies and sharing the pictures that we took with them and being part of the community. This is what community is. Next picture. And it was truly a family affair. As you say, the women loved to bring the babies back to the clinic with their families, with the other family members. It was a family affair. They felt listened to, they felt supported, they felt at home. Next slide, please. Family participation was key to being part of the community. I'll never forget how dads often came to the prenatal meetings and the postnatal meetings and with all the other children. You see their happy faces. And I can remember when when the first baby was delivered and the father came and kissed me on the cheek and said, "Thank you, Melba." And I said, "No, thank you for giving me the privilege and honor for being part of helping bringing your baby into the world." Next slide, please. In the health department clinics, this is Nurse Lee working tirelessly. We all work tirelessly to make sure that our patients had, our clients had what they needed, not just the prenatal care, but that they had food security, that they had family planning information that they needed, but that we all work together as a family. Next slide, please. Now, since I'm teaching at the University of Michigan Flint, what I'm doing is encouraging the next generation of students to consider midwifery and nurse practitioner positions. Here you see one of our students, one of my former students, Michaela. She is presently a student at Frontier Nursing University studying midwifery, and her cousin Kevin. And he will be taking family nurse practitioner courses in the near future. So I'm very proud of them. So I feel like, yes, I am encouraging the next generation. Next slide. And this is a picture of one of my midwifery friends, Marla, and we met on the road traveling to Frontier, traveling to Kentucky for our midwifery bound. And as it was indicated, I'm from class 4, and midwifery bound at that time was held at Berea University or Berea College. But Marla and I, Marla being from Michigan also, we traveled together. We met on the road to travel to Frontier. And this picture was taken at one of the ACM conventions, probably about 15 years later. Next slide. So community, even though I'm not working as a midwife, directly as a midwife at this point in time, community work never stops. And I'm sure you're familiar with the Flint water crisis that happened several years ago. That is still an issue today. But here I am at a church event in the community of Flint, where we're giving out water, and I'm working with a young mother that is that's not breastfeeding, but she's bottle feeding, but giving her information about how to add the bottled water correctly to the infant formula, and to making sure that she's coming in to get the bottled water so the infant will not have to be exposed to the lead contamination water. We also gave out, as you see, the filter in her hands. So I'm still looking forward to the next chapter of what I'm going to be doing after I retire. Because I'm sure it will be working in the community and working with, right now I'm working with the Michigan Maternal Mortality Review Committee, looking into the problems of maternal mortality. Thank you.
Well, thank you, Dr. Kraft-Blackshire. That's amazing, absolutely amazing work you're doing with the Detroit and Flint communities. And it's so fun to hear you say Operation Get Down, because of course, being from Flint for all these years, or Detroit all these years, I remember that very vividly. But you know, it's the work that you're doing in the community that is making such a difference with mortality and morbidity rates, and we know that. We just have to get out into the community a little bit more to show. Dr. Gianellis, are you just about ready for the next presenter? Okay, looks like it's coming. Then this is Dr. Kate Wilbur. Just a minute. She and has practiced as a midwife for over 20 years, as well as teaching nursing and midwifery students over the past 17 years. With specific interest in midwifery education and workforce, her professional goals are to ensure excellence in midwifery education and practice, and to grow the midwifery profession so that everyone has access to compassionate expert care. In addition to teaching at Frontier, she is the chair of the ACNM's Division of Research Workforce Committee. She is an immediate past president of the Georgia ACNM affiliate, and she's a director of the Emory Decanter Labor Support Volunteer Program. So welcome, Dr. Wilbur.
Thanks, Kathy, and thanks everybody for joining us. These are great stories. I'm glad to be here. So next slide, please.
Can you put your volume up just a little bit more? Is that possible?
I hope so. Is that any
That's
better?
better. Yes, that's better. Thank you.
Okay, I mumble, so I'm sorry about that. Just give me a yell if you can't hear me. So since I became a midwife, there's several times that I've had the opportunity to provide care for people who labored all alone without any family or friends to support them. Whenever that's happened, it's always been really unsettling to me, especially because in all of those instances, the patients were at some increased risk for complications. And in some of those instances, the patients spoke limited English. Sounded scary. These situations were my initial motivation to start a volunteer doula program. Next slide, please. So doula care, you may all be familiar, but I'll kind of let you know anyways. It involves continuous labor support that's separate from the care that midwives, nurses, and physicians offer. It's the kind of care that would be given by a well-informed family member who's focused on the holistic comfort of only that one pregnant person. Increased access to doula care, especially in under-resourced communities, can make a big difference in improving health. It's been tied to decreased maternal anxiety and depression, shorter labors with fewer medical interventions, improved communication between patients and their healthcare providers, a higher rate of spontaneous vaginal delivery, higher APGAR scores, and lower C-sections rate, which is especially important because C-sections contribute to the risk of maternal morbidity and mortality. So I live in Georgia, one of the states, not quite yet, thanks. I won't go on and on forever. I live in Georgia, one of the states with the highest maternal mortality and some of the worst health disparities for the health outcomes of moms and babies. Wanting to improve perinatal health is one of the main reasons I became a midwife, so expanding doula care seemed like a worthwhile project. A challenge was that doula support is not routinely covered by health insurance, and an opportunity was that as faculty in a school of nursing, I taught in a brick and mortar school at the time. I had access to some nursing and midwifery students who were motivated to, number one, save the world through better perinatal care, and number two, gain as much experience in a clinical setting as possible. So starting a program seemed like it could be win-win for patients and students. Next slide, please. Sorry about that. There had to be a dog on here sometime, right? This is Rose Horton. She's the Executive Director of Women and Infant Services at Emory Decatur Hospital. I had worked with some interested students previously to develop the basic bones of the program, but we were having trouble finding a supportive home for it. Then in early 2019, I met Rose at a community meeting focused on maternal child health, and a beautiful partnership was formed. Rose is also laser focused on improving perinatal health and eliminating racial disparities. Her motto is "not on my watch," which I love. But just as important as her focus is her "let's do it" attitude when it comes to getting something done. When I approached her about having a volunteer doula program, she said yes, and she's enthusiastically supported and promoted the program in every way possible since then. The next slide. So our program has developed, and here is our current organizational chart. The details are not important. I'm on the top right with the student and faculty coordinators who do most of the running of the program. My present role as program director involves strategic planning for the program, oversight and participation with volunteer recruitment and trainings, and I'm a resource for the student leaders. I serve partly as a sounding board for some of their decision making and partly as a mentor for their scholarship efforts. The volunteers from the Emory community are coordinated by two students, Tilly Field and Sarah Nassatir-Hilty, who do the day-to-day running of the organization. We added Jessica Marcus about 4 months ago. She's faculty at Georgia State University, which has a large nursing program. and she works with Tilly and Sarah to coordinate students from her school. The whole left side of the chart is made up of hospital personnel like Rose, whose resources are critical to making the program work. So you can see it definitely takes a village. The next slide, please. So here are some pictures of how we do trainings. Our trainings involve some lecture-y content about the birth process and how to provide labor support, some hands-on practice, like the photo at the bottom left shows Tilly and Sarah and a volunteer, and some training in cultural humility that's given by one of the directors at Embrace Refugee Birth Support. Embrace is an organization that supports the large refugee population in Clarkston, Georgia. I'm happy to say that we're building our partnership with Embrace. They have different models that uses volunteer doulas, but we're sharing our training and we're providing backup support for their families when their doulas aren't available. So we also have monthly check-ins with volunteers so we can see how things are going and debrief a bit. Since we started adding more non-nursing people to our group of volunteers, we're also adding some additional trainings during the check-ins. So like at our last check-in, Jessica did some basic teaching on breastfeeding support. The next slide. This is my last slide. It shows an image of the poster we presented at the ACNM annual meeting. I know you won't be able to see the details, but we keep track of feedback from patients, nurses, and volunteers, and the feedback has been overwhelmingly positive. So about 2% of our patients agree that their volunteer helped them have a positive birth experience, but the other 98% strongly agree. Some examples of patient feedback are 2 quotes. One is, Jasmine was the best. She was absolutely perfect, amazing, awesome, and fabulous. And the second quote is, I literally could not have gotten through labor without Rosalie. She provided constant support to help me through the process. The difference she made was unbelievable. And that is our program.
Well, thank you very, very much. And especially thank you for your work in the eliminating health disparities through the training and utilization of doulas, the volunteer doula program. I'm sure there are more women that you don't even know about that are so touched by the people, the doulas that you've connected them with. So thank you for that. Okay, so our next presenter, Dr. Ummenyan Outlaw. She is a CNM who matriculated through CNAP, then a postmaster's women's health nurse practitioner program, then her DMP program at Frontier. She graduated in 2019 and began full scope midwifery at a large hospital system in the beautiful city of, hopefully I can say this right, Altamonte Springs, Florida. She is currently the nominating committee chair for the Florida Council of Nurse-Midwives. She serves as a women's ministry leader and faith community nurse at her local church. At the onset of the pandemic, Dr. Outlaw founded an online support group focused on helping antepartum and postpartum patients to cope with the COVID isolation through some therapeutic listening. And this group is still going strong today. So it shows again, you know, seeing a gap and filling a need. Her passion is to see women and birthing families experience all that midwifery has to offer. Her care philosophy is healthy woman person equals a healthy family equals healthy communities. So go ahead, Dr. Outlaw.
Thank you so much, Dr. Collins-Fulea, and everyone for being here this evening. Next slide. Our project we implemented was a quality improvement project at one of the local hospitals here. So we have a large hospital system. We chose to do it at one of our smaller hospitals, which is over 100 years old, community hospital. And we wanted to look at what the gaps were in the care. So one of the things that we found out is that there's a gap as far as our team engagement, labor dystocia. We did an audited feedback process, but getting the information to the team was going to be the pivotal part of making a difference in this project. Next slide, please. So our little small hospital, we have over 300 births per month, approximately, and they're topping that out, getting closer to 320, 350, getting closer to 350 during the actual pandemic. And because we're in a rural area, we're in a suburban area, we thought about what the needs were based on our clientele. And our patients are more affluential patients, but our cesarean section birth rate was very high. Next slide, please. Our team did a cause and effect analysis, and during our evaluation, we found that 70% of the NTSV, Nellie Paris term singleton vertex, meaning one woman was pregnant for her first time, baby in a head down, full term, 37 weeks or greater, and that they were having cesarean sections, but only 26% for labor dystocia, but only 26% of the time did they actually meet criteria. So there was a huge gap in the care, and we found that standardization was part of that. And another part of that was how the team's actual outlook on the process. They didn't feel like they had a voice. They didn't feel like they could make a difference. So we came up with a strategy on how to address that with creative ways in order to address the team perspective on how we can make a difference in the cesarean section birth rate. Next slide, please. So our target was to reduce our cesarean section from 29.1% down to 24% within a 90-day period. Next slide, please. One of the ways that we decided to do that was we wanted to celebrate those who were engaged, those who were going to be a part of the process, so our physicians and our nurses. So we created a wall of fame for our physicians and a hall of fame recognition for our nurses. And as you can see from the pictures, they were all in, they were all engaged because we recognized the hard work that they all put into it. It takes a lot of labor-intensive work in order for a woman to push. The new practice guidelines said that most people, birthing people that give birth, should push at least 4 hours if they have an epidural, and 90% of the people have epidurals. So we wanted to really engage our team, and by engaging our team, we were able to increase their engagement. We were able to increase their perspective and their outlook by celebrating them. Next slide, please. We also have creative ways of keeping everyone on the team to let them know that we were doing a process improvement, quality improvement project, and we became OBPI superheroes, meaning that we had the power to make a difference. So we had pins and buttons and capes, and I became a walking billboard by wearing t-shirts, themed t-shirts, in order to keep everyone. So anyone that came on the floor would see the t-shirts and say, what does that mean? What is that big S? Why are you wearing that S? What is a cape all about? That was family members, administration, nursing team. They're like, oh yes, that's right. We are doing a quality improvement project, and it kept the momentum going. Next slide, please. Sometimes when you implement a project, sometimes it just doesn't go great like you really, really, really wanted to. And everybody's like, oh my God, another piece of paper. So we had to come up with strategic ways, but once we found strategic ways in order to support our team creatively with the buttons and the t-shirts and the pins, they themselves, the whole project took a life of its own. And as you can see, that the nurses began to really take on the ownership of the project. Next slide, please. So we developed something. We found that if the patients have a doula, they have great outcomes, wonderful outcomes. But what happens if we doula the nurse? So we created this mentoring and coaching, helping them to implement new guidelines. If you have a new guideline and you just hand it to a healthcare professional, we'll figure it out eventually, but not always as successful as we could be if we had mentoring and coaching. So we developed this just like we did for the patients, giving them the time that they needed, support one-on-one. I did the same thing as a project manager for the team. And by doing so, we helped to meet their psychological needs. They felt psychologically safe to question the status quo when a C-section was called and it wasn't necessary. They felt empowered, that their voice had power. And even the physicians felt that there was a stronger communications between the nurses and the doctors. Next slide, please. And as you can tell, one of my favorite slides is, they ask us, how did you do? Well, we made a difference. As you can see, we implemented doula the nurse at our third cycle because we had a huge uptick whenever it became busy or the unit was full. We saw that our C-section rate went up. But by douling the nurse, giving them the support, we saw the number come down. So you say, how do you doula the nurse? Well, what we would do is when they push about 2 hours, usually at about 2 hours, they would call a cesarean, usually at 2 hours. Everyone gets super tired, physically tired, psychologically tired, emotionally tired, family, physician, midwife, nurses. So at right about 2 hours, I would go in at the bedside and tell everybody to go away. I would put aromatherapy on. I would wipe the mom down. I would tell her to, shake it all off, and tell the nurse to go chart, catch up, because you're thinking about, I got a chart, go to the restroom, relieve yourself, physician, midwife, go out for a little bit, reset. And because we did that, we saw our numbers go down. And at the end, we had a shift below the mean, and our number came down to 19% was the lowest that we had. Next slide, please. And when you implement and you empower the team and you're creative, you make it fun. Even though it's hard work, quality improvement is hard work, you can truly make a difference. And we did that in the life of one of our patients here. This young lady was able to push 2 hours on day shift, 2 hours on night shift, and had a vaginal birth and was successful. If we empower the team and we doula the nurse, we can have great outcomes. Great doula for the mom, doula for the nurse, doula the doctor, doula everybody. But being creative, we can truly make a difference and help promote physiologic birth. Thank you.
I think that's going to be our new mantra, doula everybody. Thank you for promoting physiologic birth. It sounds so simple, but we all know we have to be intentional if we really want to see a difference and let birth occur as it was meant to occur. And I love the idea of doulaing the nurse, doulaing the nurse. That is a great idea. I think we're going to have to spread that one. So our final presenter tonight is Dr. Dolores Polento. She recently joined faculty at Frontier Nursing University as a clinical bound team leader and a course faculty. She's a graduate of CNAP Class 15 in 1997 and has been in private practice in rural communities in Pennsylvania and Kentucky. Most recently, she was part of a team of midwives that established the first full scope midwifery practice at the University of Kentucky. During her time at UK, she served as director of the midwifery clinic and established a successful group prenatal care program for women in recovery from substance use during pregnancy. She's active in the Kentucky Board of Nurses CPM Advisory Council and is serving her second term as a treasurer of the Kentucky affiliate of ACNM. She is also Kentucky's team leader for the Institute of Medicaid Innovations Midwifery Learning Collaborative, which is a 3-year initiative to promote and improve statewide midwifery practice. Dr. Polento has a strong belief in the birth center model of care and is active politically in Kentucky, where birth centers don't exist yet, all right? She advocates for the removal of barriers to the development, and I'm sure she will probably be one of the first ones opening one. Dr. Polento and her husband own a home care agency, which serves central Kentucky area and will be opening a second location in Melbourne, Florida. So welcome.
Thank you so much. It's really an honor and a privilege to be among such an esteemed group of midwives making an impact in their own communities. And I'd like to share with you a program that I would like to take all the credit for implementing, but it was really the result of many individuals coming together to provide holistic, multidisciplinary care for women with substance use disorder during pregnancy and in their first year postpartum. So first slide, please. The BRIGHT program at the University of Kentucky stands for Birth and Recovery Integrating Group Holistic Treatment, and was developed to provide this population with weekly group prenatal care guided by a CNM in collaboration with maternal fetal medicine, nursing, social workers, and recovery counselors. Next slide. The patient and the family were the focus of care, and although the setting was group care, each patient had individualized care tailored to integrate their recovery with the normal, monumental family event that is welcoming a new baby. And this is Brandon, and he is one happy partner holding a healthy new baby girl named Rowan. Next slide. Just some backstory. Medication-assisted treatment, or MAT, during pregnancy with either methadone or buprenorphine is the standard of care for pregnant women with substance use disorder. Methadone is a Schedule II medication that can only be dispensed in opioid treatment programs. However, buprenorphine is a Schedule III medication that can be prescribed in an outpatient setting. Prior to implementing the BRIGHT program, I spent time with the MFMs that were caring for the entire population of women with substance use disorder at the University of Kentucky. I completed the SAMHSA training to obtain the DEA-X waiver to be able to prescribe buprenorphine products. Some of the women that were coming to care would wait up to 4 hours to see each provider in the multidisciplinary team. And it was thought that creating group care instead would fill that gap in care and be more patient-friendly and efficient. So the team considered the evidence that interprofessional collaboration in a group setting for prenatal care could manage the complex health and psychosocial needs for this population, and the BRIGHT program was born. Next slide. We utilized a waiting room, which was divided by a privacy screen. Women would arrive, they would provide a urine specimen or drop a urine specimen, record their own weight and vital signs in their individual folder, and then group discussions would begin. Next slide. Each week, there would be 2 new topics for the group. One topic would cover prenatal education. The other topic would cover recovery from substance use. And it was anticipated that it would be a big adjustment for the patients, but it became an opportunity for them to socialize and get to know each other. And this was a positive addition to their care. Next slide. The nurse and the midwife would work together, providing the prenatal education. Then social work and counselors would work together to provide the recovery education. A few topics that the groups would cover, including smoking cessation, diet, breastfeeding, neonatal abstinence syndrome, minimizing infant withdrawal symptoms, infant massage, and relationship dynamics. Next slide. At some point then during the group discussion, the midwife would see each woman behind the privacy screen, measure fundal heights, listen to fetal heart tones. The midwife would then determine if the woman had any privacy, needed any privacy to ask any questions that were specific to her, or if she needed any further physical exam. And then if that were the case, the midwife would see that patient individually after the group ended in an exam room. Next slide. Groups were organized according to trimester and due dates. It was the goal of the program to bring patients together that had similar gestational ages so that prenatal care and education would be more targeted. Once a patient went into labor, the midwives would manage the labor and birth along with her postpartum care and discharge. The patient would return then to the BRIGHT group weekly or bi-weekly for her postpartum care for up to a year after the birth. Next slide. Since the 1970s, the treatment for substance use disorder had been methadone. But recent evidence shows that babies have less severe neonatal withdrawal symptoms and shorter hospital stays when buprenorphine is used. Treatment of substance use disorder together with prenatal care results in decreased rates of preterm birth, decreased low birth weights, less placental abruptions, as well as lower costs of care. Final slide. We found that women participating in the BRIGHT program discovered additional social support for themselves as they made connections with other women in the program. And this is what the evidence also shows. Women engaged in this type of group care had better engagement with their overall health care, and that has shown them to protect against relapse. And this is my example of my quality improvement initiative. Thanks.
Thank you very, very much. You know, the work that you're doing with women in substance use disorder is amazing. I know that you have set them on the road to recovery, as well as doing their prenatal care. So it makes a huge difference. So I would like to thank all of our presenters for these fabulous stories. You know, what strikes me the most is the passion each of the panelists brought to their work. Everyone had a different focus, but their successes are really because of their powerful vision they had, and truly an inspiration to all of us. We are running out of time, but I'd like to see if anyone has any questions. If anybody wants to just turn their camera on and ask if there's any questions. There have been all kinds of compliments flowing through the chat box there for the wonderful work everyone is doing. So has anyone got a question? Just speak up. If not, I don't know if any of the presenters have any final thoughts on either what advice about quality improvement you give to a midwife who's going to try it for the first time, or barriers you encountered.
I have a question for Dr. Outlaw.
Okay.
That is, give me some ideas of references that you use to try to help with your creative ideas for that team building, because I'm working with a group that are a little overworked and a little tired and want to leave like right at the minute that the time would be at. So I don't know, any hints of where to look for creative ideas, or what kind of referencing you did for that?
I will say that I didn't find a lot of data on it, but what I did, I went to Team Steps, look for communication #1. Team Steps is a great resource as far as how to communicate in succinct, concise ways, and in a way that both sides understand, clear cut understanding. So that's a great resource if you go for Team Steps. We got creative because we started to, I've been with the team and I know them, kind of watch their behaviors and what their motivators are. One of the things that I do try, we were a faith-based hospital, and so we do a lot of spiritual things and prayer. And as a leader, I did a love language test for my night shift crew. So that's Dr. Gary Chapman, some of you know him, does the 5 love languages. So once I figured out what their love languages were, I would speak to that in a way that was meaningful to them. And then that meaningfulness began to make them flourish. And then they took on the owners of it. So I started it off. So maybe there was some fails some places too. When I did more paper, if I gave one person one more piece of paper, you saw in the folder, they would go, oh my God, don't give me another piece of paper. And your team might feel that way too if you ask them to do one more thing. But with Doula the Nurse, there's mentoring and coaching. Mentoring means I had to show them how to do the behavior, show them how to reposition, go in at the bedside, be available at all these different times. And then coaching is that, okay, now this is how you do it. Okay, you can do it. Let me see you do it. Oh, you did it. And then celebrate it on the wall. So it was very creative. So take some of the things from here and go for it.
Ummenyan, I want to just bottle up your enthusiasm and take it home with me.
Thank you so much.
Any other questions or any thoughts from the panelists of how people can actually start to make a change in their own institutions?
One thing I would like to add is, when you want to make a change, go to your team and really spend time with finding out what makes them tick, what makes them say, they were like, our C-section rate is too high, but nobody knew what it was. And when we spent time with our cause and effect analysis and our gap analysis and doing the data and looking at the lit searches, once we had the information and we were able to get the data and give them the real true numbers and statistics, they just went to the max with it. So spending that time with them, quality time with them, listening to them and hearing them, if it's one thing, and let them decide. So when I presented something, I said, what are my ideas are? What are your ideas? When they gave me something, I would take that, whatever that one small thing was, and we just maxed it all the way out. And that's what that was one of the things I would recommend. So listening to your team, spending that time with your team is really going to make a difference, especially with a pandemic and COVID. They are still sustaining what we did. They changed the culture a year and a half later. They are still at low rates below the national rate. They're at 23% and their lowest was 17%. And so that means that, and we don't do anything else, and they're doing it. So you can do it too.
I agree with that, Minion. Teamwork makes the dream work, doesn't it?
Yes. Oh, yes.
Mhm. Wonderful. Any other thoughts? Well, I want to again thank everyone for coming tonight. We hope you enjoyed the Pechacucha style. It's great. I love seeing pictures myself and this visual storytelling event. Thank you again to our panelists, fantastic presenters. We're truly grateful, for your willingness to take the time out of your day, your evening here to share this with you. And I hope everyone has a chance to celebrate National Midwifery Week. Thank a midwife. Thank your midwife colleagues. Thank your midwives who may have looked after you. Thank yourself for what you do. And then go out and spread the word about midwifery. We need to normalize the idea of a midwife for every community. And that's going to come from us out to everyone else. So